All right. Well, thanks for everybody who's staying. So this really, let me get into this. So yeah, about me. So my name's Alex Barclay, and I'm founder and director of Fuzzy, which is a not-profit value creation company. We use people-centered design to deliver more value. It was created out of a collective, actually. It was initially quite a bit like the beginnings of OpenEHR in 2002. But what we do is we offer a whole range of different services, all related to connecting people to the right kinds of outcomes. So whether it's healthcare staff or patients who have a problem, getting the things that they need, that's the kind of stuff that we do. Alongside that, I'm also the head of education at the Helix Centre, which, as some of you might know, was set up by Lord Darcy and David Nabarro a few years back. It's part of the Institute of Global Health Innovation. There are 7 centres of excellence in total, and the Helix focuses very much on people-centred design. Yeah. So that's what I do. This talk really, the reason I'm here, I was talking to Rachel about it, it was to kind of poke a little bit of an eye, a bit of a finger in the eye of the OpenEHR community, and it kind of connects very nicely to what Luke was saying earlier this morning, certainly to what ePatient Dave was saying. Really, it's urging OpenEHR folk to take a people-centred design to delivering the kinds of outcomes that we want to. What I'm going to suggest and hopefully demonstrate is why OpenEHR might fail, why various electronic health record and other kind of ICT projects fail, what the cost of that is, and how not to fail as well. So that's what I'm here to do. Now, just to set the scene a little bit, this is the vision and the mission for OpenEHR. It's got some really good stuff in terms of the kind of, where we want to get to, why we want to get there, and so forth. And it's very pretty clear on the what of things as well. There is, I think, a really big ambition here. So delivering a world in which healthcare routinely obtains benefit from ICT. That's huge. That's a really, really huge and very, I think, praiseworthy ambition. And then here, there is the kind of the how. The what. So, we'll do it by constructing this kind of open vendor-neutral platform and so forth. And through this, there are some mentions of people. So there is the kind of the connection to, let's say, lifelong patient-centric EHRs. There's also clinical engagement, so engagement with healthcare professionals, and trust. These are very human attributes. Now, if we look a little bit more broadly, I'm not expecting anybody to be able to read all of this small print. Again, we've got, in effect, a very praiseworthy set of things that OpenEHR and the OpenEHR movement more broadly wants to deliver to. So we've got an explicit focus on technical innovation and interoperability, and we've got things like standards-based frameworks and so forth. And there is this, quite rightly, this focus on the technical elements of joining up different types of machine, let's call it. Now, what's less explicit is the how. This is a lot of the what, but what's less explicit in this is the how. And really, this brings me to my hypothesis about why OpenEHR might fail. Basically, OpenEHR needs more than a vendor-neutral EHR platform to achieve the vision that we've just seen. It must effectively leverage technology, and in order to be able to do that, success hinges on collaboration and engagement with all stakeholders: patients, healthcare staff, caregivers, admin, so front office, back office, everybody who is involved in the system of healthcare, that whole healthcare ecology. My point here is this is not made explicit in the OpenEHR movement, and it's not made explicit by OpenEHR Foundation. So what I take from that is that we're not incorporating the learning that we can get from years and years and years and years and years of doing this, right? So here are some examples. Some of these might be familiar to you. It's just literally, this is a random collection of where we've had a very technical focus on the delivery of EHR or other ICT programs. But I've got as many EHR programs as I can in it. So this is kind of what I call the Hall of Shame, really. So they've got the kind of, this is what we wanted to do. You'll see some of these, this is homegrown. So this is NHS, right? This is the US, this is Dutch, that's US, that's homegrown, that's homegrown, that's homegrown, that's US, that's US, that's Sweden, right? What you'll notice, what you might notice, I'll point it out anyways, when things started. So this started in the 2000s, it's still going on, right? This started in 2000, still going on. For everything that we learned, for everything that we took on board, we're still falling through space, as it were. We're still not delivering on the promise of what ICT could deliver, right? So this is what I wanted to put to you. Now, in relation to this, and this is just a kind of very rough estimate. It's very, very difficult, believe me, to get actual figures out of what the cost of failure is and what the cost of over-focus or only focusing on technology is. If you took just those programs or those projects, you're looking at a 13 billion fail bill right there. That's the monetary cost. That's an estimate. It will be an underestimate. If you look at the intangible cost, you've got all of these types of outcome as a result of what I would call an over-focus on the technical. It is important, of course it's important, but there's something missing. So intangible costs, actually everybody, you know the expression innovation fatigue? It's a real thing. I mean, we had somebody, the team doesn't even want to listen. The IT team doesn't want to listen because it's like, we're just exhausted with all of this stuff. So, again, this is just an analysis of why this stuff is happening. So, because it's tiny writing, we've got a whole range of different reasons connected to just why these particular 10 don't quite make it, didn't quite deliver to the value that we wanted them to. And what I've done is I've looked at this because I have a kind of people-centered background, design-led approach and so forth. I've looked at this just from the kind of people-centered perspective to identify, in effect, 10 fail hotspots. This is what I found when I looked at why, using that particular way of thinking, why these projects failed. It's not to say that it's the only reason that they did. So for instance, with this one, alongside user resistance, alongside poor usability, alongside misalignment of workflows, there were things like limited customization. There were things like ineffective communication. There were things like just not really understanding from a technical perspective the great big ball of mud that was going to confront the developers as they kind of started to do the work that they wanted to do. So what I've done is I've grouped all of the inputs here, all of the kind of data points here, and I've just pulled them out and said, okay, here are 10 reasons why, from a people-centered perspective, OpenEHR and other similar projects will fail, because they don't think about this, they don't make it explicit. So, in order to think about how we can begin to correct that, and this is a message that has been given many, many times. We heard Dave said it, Luke said it, the question about adoption and so forth. I like to think about what people-centered design really is. So it isn't what it is and what it isn't. It isn't service design. It isn't UX. It isn't visual design. It comes in at a bigger point than that. So I love this guy, Herb Simon. He, I think, points us in the right direction. So he talks at things that have a more strategic view to them. This is a really lovely kind of, actually, what do we want to do here? What are the outcomes that we're trying to achieve? It's not so much about what we want to do, per se, it's what we want, the thing that we do to enable us to get to, the desired outcomes that we're looking for. So I think her points us in the right direction. What I've done here is give you my version. So people-centered design, what is it? It's basically joining things up. It's showing you how you can join what I call street-level view, so what doctors, nurses, patients are experiencing as they come into healthcare, with the strategic view, so kind of ops, street-level view with the strategic view, which is, okay, the why we're doing it, we need I don't know, operational efficiency, we need effectiveness, we need to get people healthy, keep them healthier, etc. So people-centered design is actually value-centered, system-oriented design. We create better, more effective, more efficient relationships that pleases the stakeholders between people and people, people and things, so people and machines and machines, across the whole system of healthcare. And basically, to echo Herb Simon's point, these are the relationships that shift us from value diminishing situations, such as we just saw, to the more desirable value creating ones. Okay. And this is how we do it. So we put real people at the heart of all of our development. And we understand what, from their perspective, is actually going to drive value. What are the things that are going to change their behaviour so that we get more of the good stuff and less of the bad? And then we figure out, okay, what does that actually mean from a kind of wider value proposition perspective? What's it going to mean to, I don't know, a chief medical officer? What's it going to mean with budget? What's it going to mean to somebody who's sat at the top of a healthcare provider system? How do you quantify that? How do you make it worth it? So that's what we do. And in terms of the how, this is basically a way of thinking about designing towards adoption. And this is how we, both at the Helix and at Fuzzy, this is how we take on projects. We say, okay, how does stuff actually work? How does it connect up? How are you going to get your human to human, your human to machine, and your machine to machine, and all the kinds of integrations and communication working in the way that you want to? What does that actually look like? So we take this and we'll look at, I don't know, particular care setting or numbers of care settings, different use cases, and we'll design through the system to make sure that it all joins up. Now I wanted to show you a couple of examples of how we've done it. So this one is Pharmaco. This is Access and Adherence Service, people living with HIV. It's Pharmaco and NHS. There were low treatment adherence rates, suboptimal outcomes, clinical outcomes, much higher cost to serve and so forth, and a lack of capacity and information about particular types of patient, an inability to access the patients and understand what's going on for them. What we did, how, multidisciplinary team of experts, so patients, HIV specialists, technologists and so forth, looking at that stack, looking through the whole of a system, particularly use cases, what was causing drop-off and so forth, understanding how that worked, understanding how we could connect it all together. In the end, developing a very, very simple product that connected the why a patient was feeling bad as a result of their treatment, the kind of the side effect itself, to a note which was then attached to their EHR, so that when they got into the consultation with their doctor, the doctor go, oh, I see, you've been suffering from six rounds of diarrhea per day on your way to work. Let's see what we can do about that. You know, so really enabling the doctor to focus on what the problem related to adherence was, and also enabling the patient to sort of talk about what was going on. Super simple. It's rolled out in the States and Canada, and basically the estimate was about $20 million in savings. So it ticks the kind of value to whoever it is that's funding it box as well as making it good for doctors, good for patients. That's number one. Number two, bowel cancer care optimization, colorectal cancer, third most common cancer. Early detection saves lives. Wasn't happening. right? Wasn't happening. And working with Spirit and some members of the NHS to look at how we could change that situation. Again, 80 experts. So these are patients, anaesthetists, specialists in bowel cancer. So right the way across the stack, we've got different kinds of technologists in there as well, so front end, back end, you name it, all in there. Looking at where we could really connect to particular use cases, deliver the most value, and how that would work, and who it would work for. So again, pooling that kind of collective knowledge, understanding where value would be realized. You can't see this stuff, but this is basically a map of all of the human to human, and also the human to machine and the machine to machine interaction. And we pick out use cases and then work on that to see where we thought most value would be delivered most quickly. Again, outcome, multi-millions identified through that project, and it also gave us a model of a way of working that we could go and use elsewhere. So we've been talking to and working with some folks in the States about that. Also, in terms of fail hotspots, less user resistance, more usable, lower op costs, etc., etc. So it's always delivering value back. Third one, this is Telehealth Co. They were really struggling. They're kind of an online consultancy service and pharma service, missing their cost reduction targets, missing their service level standards, lots and lots and lots of complaints, lots of people kind of turning off from their offer. Again, working through that kind of deep, what I call the kind of deep and wide analysis of all of the different sorts of relationships and interactions that happen across the whole of the service delivery system, saying, okay, where can we create value? How can we do that relatively quickly? How can we do that in a way that leverages the technology, so the use of electronic health records, but also just a great experience from the supplier side. So doctors were supplying their services for the consultancy, as well as pharmacists, as well as people just doing back office stuff, and for the patients, so doing all of that. Again, the outcome. This took 2 weeks, so really fast. 2 weeks to identify 30 quick win opportunities, which they have now implemented, and they have actually, as part of their turnaround plan, because they were really going down. Quick win opportunities, and integrating that into the turnaround plan. So they're now kind of, I think, back in the black. Okay, so summary. This is what this kind of approach. This is kind of the how part of people-centered design. This is what this can deliver. I think this one is super important as well. Back, tend to think about things in quite static ways. New technologies coming in all the time. A new culture of healthcare service usage is also coming. The expectations are really changing, really moving around. So I think that's important. But obviously down here, making the case about why you'd want to do this. All right, so 5 minutes left. I don't know if have you guys seen First Man film? Do you know First Man? Oh, I'm alone in the room. I'm alone. Okay, so First Man has got Ryan Gosling playing Neil Armstrong, putting First Man on the moon. And Ryan / Neil says this line, which is, we need to fail down here so we don't fail up there. No compromises, only perfection will do. And this kind of connects to the learning theme that has been, I think, running through lots of what has been said this morning. And basically, people-centered design, because you're involving people all the time, right the way through the kind of the development process and actually the origination, like what do we want to do here, part of things. What you're doing is you're creating fail-safe all the time, because you're talking to people. Does this work for you? What would work for you? How might this work for you? How is this going to be enacted in operational terms? What is it? What else do we need to do? How can we optimize? How can, etc. So you're creating a situation where you're building learning in all the way through. You're improving all the way through. You're de-risking, and you're creating fail-safe situations that will deliver much more success to you as you go. So just coming back to here, that's the what, that's the why, and the where. My point is we need, I think, to really turn up the volume on how OpenEHR connects to the patient and the healthcare staff experience. Right? That's really where this is heading. So what I've done, what we've done is we've also created. Let me just go back one. Pre-launch. This is a handbook we can use to work with other OpenEHR's and other folk in technology, ICT units. So pre-launch, originating OpenEHR projects. Launch prep, setting up the project. In-flight, so the running OpenEHR projects. And then post-mission evaluation of that project. So this is a kind of like the how we can join all of this stuff up and make it work together so you get that value that is promised. So that's it, just to wrap up. Thank you for the time. Basically, my view is OpenEHR is fantastic. It's a fantastic movement, fantastic foundation. There is a bit of a fly in the ointment. There's something missing, and to me that is that explicit emphasis on outcomes related to human beings. So I want to see OpenEHR kind of connecting all of these dots up, if you like. But I also would be very, very pleased to hear from you guys, either now or some other time, about how we could make that happen. But I would urge you, to the point about leadership earlier as well, that part of the discussion, knowing what people care about, knowing what they want, knowing what an ICT director wants, what the proposition for them is, what would get them out of their seat and along to one of your demos. That's the very beginning of understanding what people-centered design is. What's the proposition for all of those human users in the service ecosystem? That's it. Thank you very much.
You've got a minute for questions if you want to take any.
Anybody?
Can I ask what would be, in 1 minute, what would be our, as the OpenEHR International, what would be an actionable first step that would be meaningful?
Show them the deck. Show them the deck.
Well, but is that an action? I mean, that's reading.
Okay, so an action would be.
What do I go and tell in the next meeting if I'm in a room with Rachel and say this?
Okay, so I'd say the vision, which is to achieve this world where ICT delivers these benefits, and the how is incomplete. We need to make explicit the need for a people-centered approach that connects people to the machines in a way that delivers those outcomes. We've got a handbook, a bunch of people that can help with that, making sure that the projects that we set up do that, so that you can deliver and implement in a way that delivers the outcomes that we want. That's what I would say.
Okay.
Can I just come in a minute? So I'm Phil Cozen. I work very closely with Luke on the London record.
Yeah.
And I guess one of the bits that's missing for me is that in the early stage of a program, yes, setting the vision, this is what we want to achieve, the human person-centered outcome, absolutely important. The problem is at that stage, the answer isn't necessarily OpenEHR. And it's how you join those bits up to create the clinical pull, the excitement, get over all this transformation fatigue.
Yeah.
So this is where you want to go. But actually, when we started on the UCB work, we didn't know the answer was going to be OpenEHR. And that's the big challenge I see.
So I think it's, so I flip it slightly, say, right at the beginning, so to origination, what are the right questions to ask? Who do we need in the room to help us answer them? That origination point is so, as you're describing, it's huge. It's a kind of, what's the truth? What is the truth? And that kind of stage of things, the kind of pre-launch stage, that involves lots of discovery, lots of candid conversations, lots of actually, we thought it was that, but it isn't. We don't think it, and that's about leadership. So it's about candour, about leadership, about having options as well, and not thinking you know what the solution is until you've actually explored. You know, you've got your hypothesis. You're hypothesising right at the start. You've got your, and then you begin. So my view would be that's the opportunity to set it up right. And you know, if you said, well, OpenAIR isn't the right thing right now, okay. You know, but again, you'd evidence that, so you know why you're making that decision.
Yeah.
And that's, I mean, that is about people. It's asking people, what do you think?
It's time.
But this is
Time.
not
To hear
discussion. It's not